Thank you, Manjula. Good afternoon to all of you. It's a very pleasant experience to come back to Kandy and to meet all my good friends and colleagues. And I will try to continue from where we stopped, starting from kids and then moving towards females. And the last bit of we are talking about the complicated. As Manjula said, we will try to include females in this particular topic. So to begin, what is a complicated urinary tract infection? Well, anything other than simple, it's complicated. So you need to know what is simple UTI to come into the conclusion of a complicated UTI. So typically we are looking at an infection in the urinary tract due to appropriate susceptible bacteria, and mainly we are focusing on UTIs, afebrile, non-pregnant, immunocompetent female patient. That is a typical simple UTI. Anything other than this we consider as complicated. So why it is important that we should go into the depths of the complicated UTIs? These occur in the settings of pre-existing metabolic, maybe diabetes, maybe functional, structural abnormalities of the urinary tract. And the pathogen could be virulent or maybe unusual. Of course, can involve both upper and lower tracts. The complicated UTIs can carry higher risk of treatment failure and recurrences, and as mentioned earlier, the higher morbidity and mortality, and end up with a poor outcome. As compared to simple UTIs, here the patients will require longer duration of treatment courses, different antibiotics, and sometimes additional interventions, investigations to dig into the matter and then to correct whatever the underlying cause. Of course, in Sri Lanka, we don't have much data to show, but I'm sure the figures would be the same, if not for worse. And the USA figures 1.8% of all annual hospital admissions will fall into the complicated UTIs. And 20% of the healthcare associated bacteremias, they are originating from the urinary tract. And in our urology setup, urological inpatients, almost up to 10%, they will be having complicated UTIs. That will show the magnitude of the problem. As Manjula said, when we talk about the common belief is females are more complicated than males. But when it comes to the UTIs, the male UTIs are more complicated than females. So when we categorize the complicated UTIs into different entities, and one particular group is male UTIs, which is by definition a complicated UTI. The other category of patients who are having infections occurring in anatomical abnormalities. This could be obstruction of the upper tract or maybe the lower tract. In the case of upper tract, obviously the hydronephrosis will be evident, or maybe the presence of urinary tract calculi. And rare instances you will find colovesical or intravesical fistula. And the next category is immunosuppressed or the compromised patients. Commonly this part of the world, the majority having diabetes, poorly controlled diabetic patients are not very uncommon in our practice. And then immunosuppressants and patients on steroids, post chemotherapy, and elderly and patients with HIV. Another subgroup, we are dealing with atypical organisms causing UTI. Recurrent infections despite adequate treatment, and particularly in hospital setup, we talk about multi-drug resistant organisms which are badly emerging and then spreading. And as Taha mentioned, the infections in the pregnant females, even asymptomatic bacteria, we consider very seriously, and that will fall into the category of complicated UTIs. And then when it comes to urology practice, any instrumentation, any intervention pertaining to the urinary tract, and to begin with, it's a complicated UTI, which could involve any surgical procedure or maybe simple catheter change, catheter replacement, or stent revision. And patients on clean intermittent catheterization, they are also at a higher risk. The recipients of renal transplant and the spinal cord injury patients, that will make another category. And those who are having impaired renal functions, undergoing dialysis or anuric patients, they will also have a higher predisposition to complicated UTIs. Prostatectomies and radiotherapy category is considered another subgroup that we need to look into. So of course, etiology, when it comes to UTI, we talk about the perineal and the rectal flora, which is same here even in the case of complicated UTI. The E. coli, which will be the leading cause, maybe even up to 50% of the healthcare associated UTIs. But this is not the case. The picture is much worse when we talk about the atypical organisms and more virulent organisms, particularly the Pseudomonas species and multi-drug resistant organisms such as ESBLs and the CREs. And fungal infections are also seen in immunocompromised and long-term hospital patients. So this is the type of spectrum that we need to deal with when we talk about complicated UTIs. Another side of the story, when the patient is coming with urosepsis, they can have complications, which could be local or systemic, could be acute or chronic. Now, if you look at the right hand corner, this will indicate the top part. These are the acute local complications such as pyonephrosis, renal or perinephric abscesses, as opposed to acute systemic complications such as septicemia, shock, multi-organ dysfunction, and could end up with a death. And we in our common practice, death due to urosepsis is not that uncommon, particularly due to late presentation and poor the identification. The other side of the story, chronic complications, again starting with local, including renal scarring, and chronic pyelonephritis is not an infection, but it's a globally scarred kidney due to previous recurrent infections. And there are special forms of chronic pyelonephritis such as xanthogranulomatous pyelonephritis, where deposition of orange deposits in the kidney tissue, usually following obstruction. And the systemic complications are hypertension and recurrent sepsis. Now, if you look at this the slide that will show a series of images, CT images, patient with pyelonephritis and the sequelae. You could see starting from the renal abscess, the first slide, and the second slide will show the abscess has basically merged with the perinephric area, the perirenal abscess, and it can track down along the psoas abscess. And the bottom here, another special entity, emphysematous pyelonephritis. By definition, emphysematous pyelonephritis is caused by gas-forming organisms, and it's a form of necrotizing fasciitis or similar condition which will involve the kidney. In fact, this is one of my patients who ended up with the non-functioning or almost lost renal tissue, and finally ended up with a emergency nephrectomy, one of the rare instances other than renal trauma. The nephrectomy here could be life-saving if the situation is so bad, like in this case. So when it comes to the diagnosis of complicated UTIs, there could be a significant confusion and there could be uncertainty, especially when the patient presents with atypical presentation. So in addition to classical symptoms, one should look at fever, chills, flank pain, and particularly if you are dealing with the elderly, immunocompromised patients may be coming with delirium or change of mental status. Some patients, the presentation itself could be septic shock. You need to focus on multiple antibiotic resistance in their history and recurrent UTIs. And diabetic patients rarely can present with diabetic emergencies complicated with UTIs. The second part, when you evaluate a patient, you need to see whether this patient is at higher risk of developing a complicated UTI. You could see here, starting from pregnancy, immunocompromised patients, renal transplant, abnormal urinary tract function such as neurogenic or dysfunctional bladders, post-urological surgery, renal failures, and those who are on long-term catheters. If you are encountering a patient then with a UTI falling into these categories, probably you are dealing, or this patient could be heading towards a complicated UTI. That has to be kept in your mind. Further workup, as the previous speakers mentioned, and you start with the urine sample analysis when appropriate. Here, when you are talking about a complicated UTI, most of the time you may have to collect a blood culture, particularly if your patient is severely ill and septic. It has a greater therapeutic value because sometimes when you encounter atypical organism in the urine, you are not quite sure whether it's a contamination or whether it's a real pathogen causing the problem. If your blood culture and the urine culture are compatible, and then you are quite certain you are dealing with the atypical organism which is causing the sepsis. You may collect additional urine samples at the time of decompression of the upper tract, particularly at the time of stenting or the insertion of a PCN. The infected sample could be collected, which could be positive, though your first urine sample could be negative. And if you are draining the abscess, perinephric collection, the pus could be sent for culture and ABST. The role of immunomarkers is quite important. Inflammatory markers is quite important in the case of complicated UTIs, and one should not forget that neutropenia and thrombocytopenia, they are classical features of severe sepsis, though you expect to see neutrophil leukocytosis. The imaging, though the imaging is not very useful or the mandatory according to the guidelines in the simple UTIs, here the imaging has a major role to play. So if you are dealing with a complicated UTI, the initial non-invasive ultrasound scan KUB, but very importantly, you need to focus and find out what exactly you need to gather. Particularly, you can look at the upper tracts. You can see whether there are any complications of the UTI, such as abscess and the collections. And in the case of recurrent UTIs, you need to see the residual urine after emptying. Non-contrast CT KUB has a role, especially if you are suspecting a calculus. Here you could see the CT showing obstructing renal calculus, ureteric calculus. Another common encounter is you see a patient with classical ureteric colic, maybe with sepsis. You do the CT, it only shows upper tract fullness without any calculus. So as commonly we encounter, it could be recent passage of a calculus. At the same time, never forget this, there could be still ongoing obstruction if it is due to a stricture, or as we commonly encounter in these days, poorly controlled patients who are presenting with necrosed shaft of renal papilla which are obstructing. And I had a chat with Manjula just before this presentation, and he also confirmed he has encountered quite a number of patients in the recent past. My experience is also the same. So contrast enhanced CTs has a limited role, particularly if you are suspecting a renal or perirenal abscess, and then if you need further information before drainage. When it comes to treatment, if your patient is severely septic and acutely ill patient, your resuscitation is very important. So you start with your fluid resuscitation, and if the blood pressure is not picking up, then of course you need to move towards your vasopressors, particularly noradrenaline in the early phase, and you need to cover with broad spectrum IV antibiotics. And remember, if you are dealing with an acutely ill patient, team approach is more appropriate. The team could be the physician, surgeon, urologist, intensivist, and microbiologist, and you may need the support of the radiologist, nephrologist, and sometimes the endocrinologist. But remember, the important thing is, when there's a team involved, there should be one person always taking the lead to coordinate the entire team. Most of the time what we see is there's no coordinating clinician. and ultimately the patient becomes nobody's business and then end up with a poor outcome. Always we start with empirical antibiotics, and you can get some guidance in the case of a recurrent infections and the complicated infection based on your last positive culture to begin with. And then sooner you should be switching towards the targeted narrow spectrum antibiotics with your microbiology advice. These patients, they may need a longer duration of antibiotics, which could be from 10 to 14 days to even up to 24 days depending on the improvement. The choice of antibiotics, you have all the big guns here. I would say because of the antibiotic resistance, you need to be extra careful before starting all these new drugs, the higher drugs. Please seek your microbiology guidance, and then you can come to a consensus whether to start or not. Now, unfortunately, other countries, the quinolones will be the first line of treatment for febrile pyelonephritis. And for this country, we don't have that option available because this has been abused, and most of our patients, because in the recent study shown 80% of our patients who are resistant to quinolones, ciprofloxacin and the norfloxacin, therefore the place in Sri Lankan setup doubtful. The aminoglycosides you can use with caution. Particularly, you need to focus on renal functions, but the amikacin and the gentamicin, they are very good the treatment options when it comes to adult complicated UTIs in renal preserved patients. Then you have your other antibiotics, the spectrum from third generation cephalosporins, and then piperacillin tazobactam, carbapenems, particularly for the ESBL organisms, and then the newer virulent ones, CRE organisms, then you need to use polymyxins and vancomycin for MRSA. So remember, never start these antibiotics without a proper consent from your microbiologist. I'm sure that will be very helpful when you go without any further options down the lane. So as I mentioned, imaging will basically tell you the underlying cause, the obstruction and the complications, so you'll be able to deal accordingly. Usually your patient should respond within 24 to 48 hours. The initial signs should be there. However, if there's a delayed response, you need to look at your antibiotic regime again, revisit and recheck. Maybe a case of antibiotic resistance. Sometimes the polymicrobial infections, more than one organism could be there in the complicated cases, and atypical organisms. If there's obstruction, you need to decompress. I will deal in the next slide. And then any perinephric abscess, emphysematous pyelonephritis, you need to deal accordingly. So this is one of the main areas as urologists we need to focus: decompression of and drainage of any obstructed system. In the case of upper tracts, if you see a obstruction, hydronephrosis, hydroureter, no point just loading with antibiotics. Until you decompress the system, the infection will persist, or at least will bounce back in no time. So therefore, the options would be for the upper tracts, percutaneous nephrostomy and the ureteric stenting. Which is better? There's an argument going on. I would say acutely ill patient who are not fit for any anesthetic intervention, then the percutaneous nephrostomy would be the best option to move ahead. However, we are again limited with the resources and particularly the human factor and the expertise available. And the ureteric stenting will need some anesthetic, particularly in the case of male patients, and then there is a theoretical argument when you stent and decompress an infected upper tract, which can virtually contaminate the upper tract or the other side also through the bladder. But in reality, there is no major clinical implication. Another important area that I need to touch upon is the lower tract. And when there's a significant residual urine in the bladder, and if your patient is having infection, no point treating with antibiotics unless you decompress. So you need to drain. How do you drain? You need to have an indwelling catheter. I know most of us, we are quite reluctant to get a catheter in when there's an infection. But if there's an infection with residual urine, definitely you need to drain to get the best outcome. And whatever the definitive treatment for the obstruction, you need to delay until your patient recovered from the acute septic status. Obviously, any abscess collection will need drainage. Most of the time we would prefer ultrasound guided drainage, and sometimes placement of a drain tube rather than just drainage itself, because sometimes these abscesses they tend to recollect, and re-drainage is cumbersome. If there's a loculated abscess, and then if you fail your ultrasound guided drainage, then there is a place for open drainage. The other important aspect is addressing the modifiable risk factors. For example, if the patient is a diabetic, poorly controlled diabetes, no point just treating every episode of UTI. You need to control diabetes and get a good control. And there are certain new diabetic medication that could lead to glucoseuria. So sometimes it may be a good idea that you speak to your clinician, the physician, and then change the diabetic medication itself. And if the patient is having urinary calculi or maybe non-obstructing renal calculi, but you need to discuss and then see whether you need to remove these calculi as a source of infection. And elderly male patients having prostatic obstruction and presenting with recurrent urosepsis, that's a clear indication for you to go and intervene surgically and to clear their prostates. So in summary, in the case of complicated UTIs, they occur in the settings of pre-existing metabolic, functional, structural abnormalities in the urinary tract caused by unusual or more virulent pathogens, and they are associated with higher risk of treatment failures and the recurrence, associated with significant morbidity and also mortality. You need to identify the at-risk population and atypical presentations and then manage accordingly. Accurate early diagnosis and focused treatment and timely referral, as Dr. Surendi Silasa mentioned, that referral could be between any specialty. That is very important to get the best outcome. So I think we will have a question session now at the end, and thank you.